Okay, so as a dental student, you spend a lot of time focused on the oral cavity, right?
Yeah, absolutely. Thinking about enamel, dentin, periodontal ligaments.
Right, and maybe the specific bugs like Streptococcus mutans causing decay or, the anaerobes and gum disease and root canals.
Those are your immediate neighbors, day in, day out.
Exactly. But sometimes to really understand patient health and honestly to practice safely, you need to zoom out a bit.
Look beyond the usual suspects in the mouth.
Yeah, and understand organisms that might not be the most common residents there, but can be incredibly significant.
Especially when things go wrong. Or even just during routine stuff.
And today, that's exactly what we're doing. A deep dive into an organism you've definitely met in microbiology lectures. It's pretty much everywhere.
And it has critical implications for everything from like a simple skin infection right up to life-threatening systemic disease.
And crucially for you, it directly impacts dental practice.
We're talking about Staphylococcus.
That's the one. It's a genus of gram-positive cocci, these little spherical bacteria. And like you said, they're ubiquitous.
You find them all over our skin, mucous membranes.
Yeah.
Just kind of hanging out as part of our normal flora, usually.
But as we'll see from the sources we've got here, which look like a good set of slides and notes covering morphology, pathogenesis, diagnosis, treatment, and those dental links, they aren't just passive bystanders.
Not at all. They are absolutely capable of causing serious trouble when they get the chance.
So the goal for this deep dive is to really unpack these sources together, pull out the important bits, especially the stuff that's going to matter most to you as a dental student and future practitioner.
Right. Think of it as the essential knowledge, not just for exams, but for recognizing potential issues in patients, understanding why you do certain infection control steps,
and appreciating how your work in the mouth connects to broader health concerns. Okay, let's dig in.
All right.
So to start, let's get a picture. What are we dealing with under the microscope? What do these things actually look like?
Morphologically, Staph species are gram-positive spherical cells. Kochi.
So gram-positive means they stain purple or blue.
Exactly. They hold on to that crystal violet stain because of their thick peptidoglycan cell wall. They're pretty small, typically around 1 micrometer in diameter.
But the really characteristic thing, the thing that gives them their name.
Ah, yes. The arrangement. It's the grape like clusters.
Right. The source mentions the Greek word staphyl means a bunch of grapes.
Precisely. Because they divide in multiple planes, they form these irregular, bunched-up clusters.
Which is different from, say, streptococci.
Totally different. Strep divide along one axis, so they form chains. Seeing those clusters is a big visual clue for staph.
Though the source notes it's not always perfect clusters in, like a pus sample.
Good point. Yeah, in clinical samples, things can get messy. You might see them singly or in pairs, maybe short chains of 3 or 4. But the underlying ability to form clusters is there.
Okay. And other basics. Motility. Spores.
Non-motile, no flagella. And non-sporing. They don't form those super tough
Yeah.
endospores like Clostridium or Bacillus.
Got it. Now, what about this capsule or slime layer thing? The source mentions something about that being a bit hidden.
Yes, that's a really crucial detail. With standard light microscopy, you usually don't see a big, obvious capsule. So they're often called non-capsulated. But electron microscopy shows they do have a microcapsule, or what's often called a glycocalyx or slime layer. It's this layer of polysaccharide stuff on the outside.
Ah, the slime layer. Okay, now that should ring bells for dental students.
It absolutely should, because that glycocalyx, that slime layer, is all about adherence.
Sticking to things.
Exactly. Sticking to host tissues, sticking to implants, sticking to teeth. It's the first step in colonization. And critically, it's a major component in forming biofilms.
Biofilms are huge in dentistry.
Hugely important. The source even uses S mutans sticking to enamel via its glycocalyx as an example. Now, S mutans is a strep, different genus, but the principle is the same. That slime layer helps staph colonize surfaces, build protective biofilms.
Which could be on things like dental implants. Or even in the water lines.
Precisely. We'll definitely come back to water lines.
Yeah.
So that seemingly minor detail about a microcapsule you only see with an electron microscope. Functionally, it's massive.
I'm connecting it right back to the mouth and biofilms? Perfect. Okay, so we've got the picture. Gram-positive coccus, often in clusters, with this important slime layer. How do we start organizing this big group? The source says there are at least 40 species of Staphylococcus.
Good question. They're in the family Micrococcaceae. But within the genus Staphylococcus, while there are many species, 3 really stand out in human health.
The main players.
Yeah. Staphylococcus aureus, Staphylococcus epidermidis, and Staphylococcus saprophyticus. Those are the ones you'll encounter most often clinically.
And the primary way to start sorting these out, especially in a lab, is based on an enzyme.
Exactly. The coagulase test. It's a fundamental biochemical test. And it splits the genus into two main groups, which generally correlates with virulence potential.
Coagulase positive and coagulase negative. Or CONS, right?
The big one, the main pathogen we worry about, is Staphylococcus aureus. It is coagulase positive.
Meaning it produces this coagulase enzyme.
Yes. The source notes S. aureus makes both free coagulase, which it releases, and bound coagulase, also called clumping factor, which stays on the cell surface. Some other less common species might make one or the other, but S. aureus is the key human pathogen defined by being coagulase positive.
Okay, so S. aureus is coagulase positive, and the others, like S. epidermidis and S. saprophyticus, are...
They fall into the coagulase negative Staphylococci group, or CONNS. The source lists others too, like S. hominis, S. hemolyticus, S. acrolyticus, S. schleifferi. It's a large group.
And this coagulase test is important because it links to how likely they are to cause serious disease.
Generally, yes. It gives us another way to categorize them based more on their typical pathogenicity.
So S. aureus is the common pathogen, the one that causes trouble on its own.
Correct. It has the weapons, the enzymes and toxins we'll get into, to invade tissues and cause disease, even in healthy people.
And S. epidermidis and S. saprophyticus are listed as opportunistic pathogens. What does that mean exactly?
It means they usually only cause infections when there's an opportunity, like if the host's defenses are weakened or if they get into a place they shouldn't be. Catheters, artificial joints, they're often just harmless residents, but they can take advantage.
And S. hominis is listed as usually non-pathogenic.
Under normal circumstances, yes. Though, even commensals can sometimes cause issues in severely immunocompromised people.
Yeah.
But generally it's considered non-pathogenic.
Okay, so coagulase positive usually means S. aureus, the main troublemaker. Coagulase negative, CIS, is the big group of opportunists, though some, like S. saprophyticus causing UTIs, are more regularly pathogenic in specific situations. The sources also briefly mention other typing methods, phage typing.
Yeah, bacteriophage typing, DNA fingerprinting. Those aren't for routine diagnosis in the clinic. They're more for epidemiology.
Like tracking an outbreak.
Exactly. If there's a cluster of staph infections in a hospital ward, for instance, these methods can help figure out if it's the same strain spreading, track how it's moving, maybe find the source. Super important for infection control, especially with resistant strains like MRSA.
Fascinating. Okay, we have the basics: shape, arrangement, classification by coagulase. Now let's get into the nitty-gritty. How do they cause harm? What's in their toolbox? Let's talk virulence factors. This sounds like where it gets really interesting.
It really is. Their arsenal is impressive. The general game plan for staph is get access, usually through broken skin or mucosa, then colonize, which means sticking to cells or the matrix, then evade the host defenses, multiply, and finally cause tissue damage.
And the virulence factors are the tools for each step.
Precisely. Proteins, enzymes, toxins, they facilitate all of it. And it starts right there in the cell wall.
The wall itself is a weapon.
In a way, yes. The peptidoglycan, the structural part, isn't inert. It triggers host responses, activates complement, makes host cells release inflammatory signals, cytokines.
So it contributes to the inflammation we see.
It does. But interestingly, it can also mess with chemotaxis, which is how our immune cells find the infection site. So it might hinder the cleanup crew.
And the capsule or glycocalyx, that slime layer again?
Back again. It's not just for sticking. It makes it harder for phagocytes, neutrophils, macrophages to grab onto and engulf the bacteria. It's antiphagocytic.
Hides them.
Sort of, yeah. And it inhibits chemotaxis too. Plus, by helping form biofilms, it shields them from immune cells and antibiotics. It's a major evasion tactic.
Teichoic acid is also listed in the wall components.
Right. Teichoic acid is a major surface antigen. It helps staph attach to mucosal cells, which is important for colonization. And it also offers some protection against complement opsonization. That's when complement proteins tag bacteria for destruction.
And protein A, specific to S. aureus.
Yes. Protein A is a classic S. aureus virulence factor, anchored in the cell wall. It's really clever. It binds to the FCC region of IgG antibodies.
The wrong end of the antibody.
Exactly. It flips the antibody around, so the part that normally signals phagocytes is pointing away from the bacterium. This basically inactivates the antibody as an opsonin, preventing it from helping phagocytes eat the bacteria.
Wow.
Plus, it has other effects, messes with complement, can be chemotactic in a disruptive way, injures platelets, can even trigger hypersensitivity. It's a multi-talented troublemaker.
Okay, so the wall itself helps them stick, hide, and mess with antibodies. What about enzymes, things that break stuff down or manipulate the environment?
Yeah, the enzymes are like their chemical toolkit for spreading, digesting tissues, protecting themselves. And the absolute key Y enzyme for pathogenic S. aureus is coagulase.
The one we use for classification, the one that clots plasma.
That's the one. It interacts with stuff in the plasma, ultimately converting fibrinogen to fibrin, the protein that forms clots.
And why is clotting plasma around the bacteria helpful for them?
Because that fibrin coat acts like a physical shield. Imagine the bacteria wrapping themselves in a blanket made of host protein.
It makes them hard to see, hard to grab.
Exactly. Much harder for antibodies and complement to tag them, opsonization. Much harder for phagocytes to engulf them. This lets them survive and multiply locally, and it's crucial for forming those typical staph abscesses.
Those walled-off pockets of pus.
Yes. The fibrin wall helps create that localized protected environment that's tough for immune cells and antibodies to get into.
Nasty. And clumping factor, the bound coagulase, what does that do?
That's on the surface. It directly binds to fibrinogen and fibrin that are already there in tissues or plasma. It helps the bacteria stick together, clump up, and also adhere to clots or damaged tissue surfaces, aids colonization and walling off.
Catalase is another one. Source says all staph are positive, strep are negative. Big differentiator.
Absolutely fundamental lab test.
Yeah.
Catalase breaks down hydrogen peroxide into water and oxygen.
Why is that helpful?
Because hydrogen peroxide is toxic. Our phagocytes use it to kill bacteria. They engulf the respiratory burst. Bacteria also make some themselves. Catalase neutralizes it.
So it protects them from our chemical weapons and their own toxic waste.
Pretty much. It gives them resistance to oxidative stress. And yeah, strep doesn't have it, so dropping H-Euro on a colony and seeing bubbles is a quick way to tell staph from strep.
Okay, coagulase build the fort. Catalase handles chemical attacks. What about spreading through tissues?
That's where things like hyaluronidase come in, sometimes called the spreading factor.
What does it spread through?
It breaks down hyaluronic acid, which is like the cement holding connective tissues together, part of the extracellular matrix. By degrading this, the bacteria can move more easily through tissues, letting the infection spread outwards.
And lipase and proteinases sound like they digest things.
They do. Lipase breaks down lipids, fats, which can damage host cell membranes. Proteinases break down proteins, degrading tissue components. Both contribute to the tissue damage and necrosis you see in staph infections.
Penicillinase or malactamase? That sounds obvious.
It is, and it's a huge clinical issue. This enzyme breaks the core beta-lactam ring structure found in penicillins and cephalosporins.
Making the bacteria resistant to those antibiotics.
Exactly, and the gene for it is often on a plasmid, meaning it can be easily passed between bacteria, which is why resistance spreads so quickly.
And DNase or nucleus breaks down DNA.
Yeah. Its exact role in disease isn't always crystal clear, but it might contribute to tissue breakdown. Some research suggests it might help staph escape from nets, neutrophil extracellular traps.
Nets?
Yeah, and neutrophils can release these web-like structures made of their own DNA to trap bacteria. DNase might help staph cut its way out.
Okay, enzymes for defense, spreading, tissue damage, antibiotic resistance. Now the heavy hitters, coxins. The source lists several types.
Right, these are secreted proteins that cause damage directly or trigger harmful host responses, sometimes far from the actual bacteria. Cytotoxins like alpha, beta, delta, gamma toxins damage cell membranes.
Punch holes in them.
Essentially, yeah. They create pores, causing cells to lyse to burst. Alpha and beta toxins are strong hemolyzins. They lyse red blood cells. That's what causes the clear zone, the beta hemolysis you often see around S. aureus colonies on bloody gar plates.
Leukocidin, Canton-Valentine, leukocidin, PVL. Sounds like it targets specific cells.
It does. Leuco for white blood cells. Cidin for killer. PVL specifically targets and kills leukocytes, neutrophils, macrophages, the immune system's frontline defenders.
So it takes out the troops sent to fight the infection?
Exactly. This directly weakens the host's inflammatory response, helping the bacteria survive. PVL is often associated with particularly nasty community-acquired MRSA strains, causing severe skin infections and pneumonia.
Exfoliative toxin or epidermolytic toxin. What does that do?
This one causes Staphylococcal scalded skin syndrome, or SSSS. It's a protease, an enzyme that cuts a specific protein called desmoglein 1.
And desmoglein 1 does what?
It's like the glue holding the outer layers of the epidermis together. When this toxin cuts it, the layers separate.
Causing the skin to peel off? Like a scald.
Precisely. You get blistering and peeling over large areas, mostly seen in infants and young children.
Okay, then there's toxic shock syndrome toxin, TSST1. This one sounds particularly bad, linked to toxic shock syndrome.
It is. TSST1 is the classic example of a superantigen. And understanding superantigens is really important.
How do they work differently from normal antigens?
Normally, an antigen-presenting cell shows a specific bit of antigen to a T cell, activating just that small group of T cell specific for that antigen. Superantigens bypass this specificity.
How?
TSST1, as the source says, directly links MHC class II molecules on the antigen-presenting cell to the T cell receptor on many different T cells. Kind of like a bridge, regardless of what antigen the T cell is supposed to recognize.
So it activates loads of T cells all at once.
Loads. Up to 20% of the body's T cells can be activated simultaneously. This triggers a massive, uncontrolled release of inflammatory cytokines, a cytokine storm, interleukins, TNF.
And that's what causes the symptoms of toxic shock.
Yes. That overwhelming systemic inflammation leads to the high fever, the dramatic drop in blood pressure, shock, the diffuse rash that peels later, muscle aches, vomiting, diarrhea, multi-organ failure. It's a medical emergency.
And it comes from a localized staph infection.
Usually, yeah. The staph are often colonizing a mucosal surface or in a wound packing or something, producing the toxin, which then gets absorbed into the bloodstream and causes systemic effects.
Wow, so the toxin hijacks the immune system to cause the damage. What about enterotoxins, also superantigens, causing food poisoning?
Yes, staph makes several enterotoxins, AEGI listed. They're also superantigens, but they act primarily in the gut. Rapid onset vomiting and diarrhea.
Yeah.
And the source highlights two key things. They're heat stable.
Meaning cooking the food might kill the bacteria, but not the toxin.
Exactly. If the toxin was already produced in the food, heating might not inactivate it. And they're resistant to stomach acid. So you ingest the preformed toxin, it survives the stomach, hits the gut, and boom, you're sick within hours. Delta toxins also mentioned for diarrheal diseases.
So from sticking factors and enzymes to break down tissues and antibiotics, to toxins that kill cells, kill immune cells, peel skin, or cause systemic shock, S. aureus really is well armed, and the source lists antibiotic resistance itself as a virulence factor.
You have to think of it that way now. In today's world, being able to resist the drugs we use is a major factor in how successful and dangerous a pathogen is.
Like the malactomase we mentioned.
That's a big one, conferring resistance to basic penicillins. But the really major concerns are MRSA and now VRSA.
Methicillin-resistant and vancomycin-resistant S. aureus. Scary acronyms in healthcare.
And for good reason. MRSA strains have acquired a gene, usually MECA, that codes for an altered penicillin-binding protein, PBP2A.
And PBP is the target for beta-lactam antibiotics.
Right, but this altered PBP2A doesn't bind well to beta-lactams. So methicillin, oxacillin, nafcillin, all the penicillins and cephalosporins, they just don't work effectively.
Making MRSA resistant to that whole huge class of drugs?
Correct. It started in hospitals, but now community-acquired MRSA, CA-MRSA, is widespread. Treating it often requires different drug classes, like vancomycin.
But now we have VRSA, vancomycin resistance.
Yes, that's the next level of concern. Strains that have acquired resistance to vancomycin, often by picking up genes from vancomycin-resistant enterococci, VRE, it severely limits treatment options. And multi-resistance, resistance to several different classes of antibiotics, is also common, especially in Con S, like S. epidermidis. It makes treatment very challenging.
Okay, that covers how they cause trouble. Now, where do these bugs normally hang out? Where do they live, and how do they spread? This feels really important for prevention.
Absolutely. Staphylococci are considered primary parasites of humans and animals. They like living with us.
Sure.
But crucially, they're also very common commensals.
Meaning they live on us without usually causing problems.
Exactly. On our skin, in skin glands like sweat glands on mucous membranes, they're part of our normal microbiome.
So having staph on you is normal?
To a large extent, yes. And certain spots are hotspots for colonization. The source really highlights the anterior near the front part of your nostrils.
How common is carriage there?
The source says 35–50% in healthy adults. So, potentially half the people you meet are carrying S. aureus in their nose right now.
Wow. Any other common sites?
The perineum, about 10%. Vagina, maybe 5–10%. And carriage rates can be higher in certain groups. IV, drug users, diabetics, dialysis patients, and significantly, hospital patients and healthcare staff.
Healthcare staff having higher rates makes sense due to exposure. And this normal presence, even in the mouth, has direct dental implications, right?
Definitely. The source explicitly says staph is part of the normal oral flora. Maybe not as abundant as strep in young, healthy mouths, but it's there.
And maybe more common in some groups, like the elderly.
Yes, the sources mentioned potentially higher prevalence in saliva of older adults, like over 70. The key takeaway is staph can be present even in a healthy mouth, just waiting for a chance if there's a break in the barrier.
Okay, so it's often living on us or in us. How does it get from person to person, or from a person to a surface and then to someone else? Transmission.
This is critical, especially for you in the clinic. Direct contact is huge, skin to skin. And hands are the #1 vehicle.
Hands of staff, hands of patients.
Both. Poor hand hygiene is a major way hell. Staph, especially resistant strains like MRSA, gets transmitted.
What about airborne spread?
That can happen too, through dried bacteria on dust particles or inhalation of droplets from coughing, sneezing, even talking.
And contaminated objects, fomites.
Very important. Things like doorknobs, bedding, towels. But in the clinic, think instruments, chairs, surfaces, countertops, anything that hasn't been properly cleaned and disinfected between patients.
So an infection could start from the patient's own staph?
Right, that's endogenous infection, like staph from their nose getting into a cut.
Or it could come from outside.
Yes, exogenous infection. That's cross-infection from other people, patients, staff, visitors, or from the contaminated environment. That's a huge issue in hospitals and clinics, driving nosocomial infections.
And getting staph once doesn't mean you're immune forever.
Unfortunately, no. The source points out there isn't lifelong immunity, which is why people can get recurrent staph infections.
Okay, let's nail this down for the dental clinic. We've got potential carriers, patients and staff, especially nasal. We generate aerosols during procedures. We touch surfaces and intimates constantly.
Exactly. Hands, aerosols, fomites, those are your key transmission pathways in the dental setting.
And understanding this is the basis for infection control.
Absolutely. Hand washing, surface disinfection, sterilizing instruments, wearing PPE, all those protocols are designed specifically to break these chains of transmission for staph and other pathogens. It's why those routine steps are non-negotiable for safety.
Makes perfect sense. Knowing where they live and how they move is crucial for stopping them. So what actual diseases do they cause? S. aureus in particular. The list seems broad.
It is. They're famous for causing pyogenic infections, pus forming, often localized, especially skin and soft tissue stuff.
Like boils and impetigo, the classic skin things.
Precisely. That's probably the most common presentation. Folliculitis, infected hair follicles. Pustules. Boils, which are also called furuncles. Carbuncles, which are deeper clusters of boils. Abscesses. Styes in the eyelid. Impetigo, especially in kids. Paronychia, around the nails. And very importantly, wound and burn infections and surgical site infections.
Surgical wounds are a big one.
Huge. Often caused by the patient's own skin staph getting in during surgery or from contamination. The source also mentions cellulitis and necrotizing fasciitis staph can be involved, but strep pyogenes is often the main culprit for really aggressive forms.
And there's a direct dental link here under skin soft tissue, angular colitis, the cracks at the corner of the mouth.
Yes, exactly. The source specifically lists S. aureus as a common bacterial cause, often co-infecting with Candida species.
Especially in denture wearers, maybe, where moisture collects?
Right, or people with reduced vertical dimension. So that's a condition you will definitely see where staph might be involved. Also, infected facial cuts or lacerations, skin bugs like S. aureus and S. epidermidis would be prime suspects there.
Okay, so not just body skin issues, but things right on the face. What if staph gets deeper, beyond the skin?
It can invade deeper tissues and organs. Can cause upper respiratory things like tonsillitis, pharyngitis, sinusitis, though viruses are more common there. More seriously, lower respiratory infections like pneumonia, especially after flu or post-op.
And the really serious deep infections.
Things like osteomyelitis bone infection, meningitis, endocarditis infection of heart valves, septicemia or bacteria in the blood, UTIs, and deep abscesses in organs like the liver or kidneys.
Osteomyelitis, bone infection, that has potential jaw relevance.
It does. While osteomyelitis of the jaws is less common than in, say, the leg bones, partly because the jaws have a pretty good blood supply, it definitely happens.
Yeah.
And critically, S. aureus is the #1 cause of osteomyelitis overall.
So even if jaw infections are often from teeth, and involve anaerobes.
S. aureus can still be involved, especially in chronic cases or after trauma or surgery or in immunocompromised patients. So you need to keep it in mind as a possibility for jawbone infections.
Got it. Then there are the toxin-mediated diseases, where the toxin is the main problem, not just bacterial invasion.
Right, the staphylococcal intoxications. 3 main ones listed: food poisoning, toxic shock syndrome, STSS, and staphylococcal scalded skin syndrome, SSS.
Food poisoning from the heat-stable enterotoxins we talked about.
Yep, classic intoxication. Bacteria contaminate food, usually from a carrier handling it improperly. They grow, produce toxin.
Yeah.
You eat the food, maybe even after reheating killed the bacteria, but the toxin survives.
And causes rapid vomiting and diarrhea.
Exactly. Quick onset, usually no fever, self-limiting but miserable.
Toxic shock syndrome, STSS, from TSST1.
The superantigen causing that massive cytokine storm, high fever, shock, rash, multi-organ involvement. A true medical emergency, triggered by toxin absorption from a colonization site.
And scalded skin syndrome, SSS, from the exfoliative toxin.
Mostly in infants. Toxin spreads systemically, cleaves that skin adhesion protein, causes widespread blistering and peeling. Looks like a burn.
The sources also emphasize nosocomial infections, hospital-acquired.
Hugely important. Staph, especially S. aureus and Con S, and particularly the resistant strains like MRSA and MRCon-S, are major causes of infections people get in healthcare settings.
Like surgical site infections, catheter infections.
Yes, those are big ones. Pneumonia, too. The combination of vulnerable patients, invasive devices, and staff's ability to spread easily via hands and surfaces makes hospitals high-risk environments. Really underscores the need for strict infection control.
And speaking of Con-S, the coagulus-negative staph, the source says they cause opportunistic infections.
Right. They're not usually primary pathogens like S. aureus, but they cause trouble when given the chance. S. epidermidis is the classic example.
The common skin bug.
Exactly. It's a master of infecting implanted medical devices. Catheters, artificial joints, prosthetic heart valves.
Because of its biofilm-forming ability, that slime layer.
Precisely. It sticks to the inert surface, forms a protective biofilm, and causes infections that are really hard to clear with antibiotics because the biofilm shields the bacteria. Leads to things like catheter sepsis, infected joints, prosthetic valve endocarditis.
And S. saprophyticus, the other main Con-S.
That one's known for causing UTIs, particularly in young, sexually active women. It colonizes the area around the urethra and can travel up. It's actually a fairly common cause of UTIs in otherwise healthy people, unlike many other Con-S infections.
So even the coagulus-negative staph aren't harmless. They're significant opportunists, especially with modern medical devices. Okay, let's really focus this now. Specific dental implications. Where does staph directly intersect with your world as a future dentist?
This is absolutely key stuff for you. First, just reiterating its presence in the mouth.
Part of the normal flora, sometimes there, maybe more in older folks. It's a potential player.
Correct. So specific oral conditions where it's involved.
We mentioned angular cheilitis.
Yes. S. aureus often involved, frequently with candida. You'll see this. Osteoradionecrosis bone death after radiation staph can be a secondary invader in that compromised tissue, usually part of a mixed infection.
What about typical tooth abscesses or root canal infections, dental, alveolar, or endodontic infections?
The sources say S. aureus is infrequently isolated from those primary infections originating from the tooth.
Meaning it's not usually the main cause.
Right. Those infections are typically polymicrobial. Lots of bacteria working together and dominated by anaerobes that love the low oxygen environment inside a dead tooth or infected jawbone. Strep species are common early on, then anaerobes take over. Staph might be present in the mix, but usually isn't the driver.
But infected facial cuts are different?
Definitely. Skin flora like S. aureus and S. epidermidis are highly likely culprits if a facial laceration gets infected.
Okay. Now, maybe the biggest connection. Infective endocarditis.
This is critical. Absolutely critical. The sources explicitly state that oral commensals, including S. aureus and S. epidermidis, alongside strep, enterococci, etc., are significant causes of infective endocarditis.
And the pathway is bacteria from the mouth getting into the bloodstream.
Exactly. Bacteremia. Yeah. It can happen just from daily activities like chewing or vigorous brushing, especially if there's gum disease. The inflamed gums provide an entry point.
But dental procedures can cause it too.
Yes. Procedures that manipulate tissues or breach the mucosa can definitely cause or increase bacteremia. Extractions, scaling, periodontal surgery, even some endodontic procedures or implant placement.
And once the bacteria are in the blood,
they can travel to the heart. If a patient has a pre-existing heart condition with damaged or abnormal valves, maybe from rheumatic fever, a congenital defect, or they have an artificial valve, these surfaces are sticky points for bacteria.
They latch on.
Yeah, they adhere, helped by things like the slime layer, form little colonies called vegetations, clumps of bacteria, fibrin, platelets. This causes inflammation, damages the valve, and bits can break off and travel elsewhere. Emboli.
And this is why we give antibiotic prophylaxis before certain procedures to high-risk patients.
Precisely. That guideline exists because of this known link. Oral bacteria, including staph, dental procedure, bacteremia, colonization of vulnerable heart valve, endocarditis. The antibiotic aims to knock down that bacteremia, reducing the risk. Understanding this pathway is fundamental.
Okay. We also touched on osteomyelitis of the jaws again.
Right. Less common than long bones, but possible, especially chronic cases, post-trauma surgery, or in compromised patients. Since S. aureus is the top cause of osteomyelitis overall, it's a potential player, even if jaw infections are often polymicrobial.
Beyond infections from the mouth, what about infection control in the clinic? Preventing spread within the dental environment. Staph seems like a big target here.
It is. This is where everything comes together. Carrier sates, transmission routes, resistant strains. One specific area highlighted is dental unit water lines, DUWLs.
The water tubing for handpieces, syringes?
Exactly. Water goes in clean, but inside those narrow tubes, bacteria grow like crazy and form biofilms, thick layers of bacteria stuck to the walls.
And staph can be in there.
Yes, the source mentions S. aureus, along with others like Legionella, Pseudomonas can multiply in these biofilms.
Now the risk is?
Aerosols. When you use the handpiece or syringe, you spray that contaminated water into the air. Patients or staff can inhale it, potentially causing respiratory issues, especially if immunocompromised. Or it can directly contaminate a surgical site.
So cleaning those water lines is crucial.
Absolutely critical. Regular flushing, cleaning, disinfection protocols are essential to keep the bacterial load down.
And beyond water lines, just the basics. Universal precautions.
Foundational. Treat every patient as potentially infectious, because nasal carriage of S. aureus is common, maybe even in yourself or your colleagues. So gloves, masks, eye protection, proper sharps handling, thorough surface disinfection between patients. It's all designed to stop bugs like staph moving around via contact, aerosols, or fomites.
And hand hygiene?
The cornerstone, repeatedly emphasized. Effective hand washing or using alcohol rub is probably the single most important thing you can do to prevent spreading staph and other infections in the clinic. Every single time you clean your hands, you're breaking that chain.
Really drives home the connection between microbiology theory and everyday practice. Okay, so if you suspect staph angular chylitis, skin infection, maybe something deeper, how does the lab confirm it? Diagnosis.
First step is getting a good sample. Depends on the site, obviously. Pus from an abscess, swab from a wound or nose, blood cultures for systemic infection, joint fluid, urine for UTI, maybe vomit or feces for food poisoning. Proper collection is key.
Then look under the microscope.
Often, yeah. Gram stain. Look for gram-positive Kochi, hopefully in clusters, often mixed with pus cells, neutrophils. It's a quick first look, suggests staph, but you can't ID the species just by looking. Less useful if it's a sample with lots of other bacteria.
So you need to grow it. Culture.
Culture is definitive and needed for sensitivity testing. Luckily, staph grows pretty easily. Aerobic or facultative anaerobic. Grows fast on standard lab media, nutrient agar, blood agar, usually overnight at 37 degrees C.
And how they look on the plate gives clues.
It can. S. aureus often forms characteristic golden yellow colonies on nutrient agar, though not always. On blood agar, it frequently shows beta hemolysis, that clear zone where it's burst through the red blood cells. S. epidermidis usually forms white, non-hemolytic colonies.
What about selective media, like that mannitol salt agar, MSA?
Yeah, MSA is useful for isolating staph from mixed samples. The high salt inhibits most other bacteria. Staph grows. And S. cerceus usually ferments the mannitol sugar in the agar, producing acid that turns the pH indicator yellow around the colonies. Most Con-S, like S. epidermidis, grow but don't ferment mannitol, so the agar stays red. Helps differentiate them.
Okay, you have colonies, now biochemical tests to nail the species ID.
Exactly. First, usually the catalase test. Add hydrogen peroxide, all staph bubble vigorously positive, strep don't, negative.
And the big one for S. aureus.
The coagulase test. Tube test for free coagulase, slide test for bound clumping factor. Positive coagulase, S. aureus. That's the defining test.
Any others mentioned?
Oxidase test DAS are negative. Mannitol fermentation on MSA, as we said. Also phosphatase S. aureus, usually positive. And DNase aureus positive. These add confirmation.
And antibiotic sensitivity tests can help too, especially differentiating Con-S.
Yes. Novobiosin sensitivity is key there. S. saprophyticus, the UTI one, is resistant. S. epidermidis is sensitive. Helps ID S. saprophyticus from urine cultures. S. aureus is usually sensitive to novobiosin, but resistant to polymyxin B.
So this panel gives the ID and critically guides treatment, which brings us to treatment. And the big elephant in the room, resistance.
Yeah, treatment often needs multiple approaches, and resistance complicates everything. For localized pus collections, boils, abscesses, maybe facial ones you see, the most important thing is often surgical drainage and debridement. Get the pus out, remove dead tissue.
Antibiotics might not work well otherwise.
They struggle to penetrate abscesses and don't work well in that environment. Sometimes topical antibiotics like mupirocin or fusidic acid are used for skin stuff.
But for deeper or systemic infections, you need systemic antibiotics.
Yes, IV or oral. Beta-lactams, penicillinase-resistant penicillins like flucloxacillin or cephalosporins are often first choice if the strain is susceptible. BL-BLI combos too.
But many strains make penicillinase, and then there's MRSA.
Exactly. Penicillinase knocks out basic penicillin, and MRSA, with its altered PBP, is resistant to all beta-lactams. Can't use them for MRSA.
So what do you use for serious MRSA?
Glycopeptides are the mainstays. Vancomycin's the classic one. Teicoplanin also mentioned. They inhibit cell wall synthesis differently.
But there are issues: cost, toxicity, and resistance.
All of the above. Vancomycin needs careful monitoring due to potential kidney toxicity, infusion reactions, and the emergence of VRSA, vancomycin-resistant S. aureus, is a huge concern, leaving very few options.
What other antibiotic classes are in the mix?
Sourceless quinolones, like Cipro, which hit DNA gyrase, sulfonamide trimethoprim, cotrimoxazole, hitting folic acid synthesis, lincosamides like clindamycin and oxalidinones like linezolid, which target protein synthesis at the ribosome, fusidic acid for skin, and drugs like trimethoprim, Cipro, nitrofurantoin, specifically for UTIs caused by S. saprophyticus.
So options exist, but resistance is the key challenge, which makes susceptibility testing vital.
Absolutely essential, especially for serious infections. You need to know what will actually work against the specific bug causing the infection. Disc diffusion is common. Using oxacillin or cefoxitin discs to detect MRSA is specifically mentioned.
And this has direct implications for dental prescribing.
Massively. You might need antibiotics for oral infections. While many respond to drugs for anaerobe strep, if staph is suspected, like that facial laceration, or maybe a complex jaw infection not responding, you need to consider staph. Knowing about MRSA prevalence, the need for susceptibility testing in tricky cases, it's all relevant.
And the broader issue of antibiotic stewardship.
Crucial. Dentists are major prescribers. Using antibiotics only when truly needed, choosing the right drug, right dose, right duration, it's vital to slow down resistance development. The sources explicitly call out avoiding indiscriminate use as a prevention strategy.
A really important point. Okay, finally, prevention. How do we stop staph spreading, especially in places like clinics?
Focus is on breaking transmission. In healthcare, isolating known MRSA patients, maybe screening and decolonizing staph carriers, using nasal mupirocin, antiseptic washes.
And broader prevention.
Two big things hammered home. One, avoiding indiscriminate antibiotic use, that stewardship point again. Two, basic cleanliness, and especially hand washing. It keeps coming back to washing your hands.
And for the dental clinic specifically, to recap.
Strict infection control always. Universal precautions, meticulous hand hygiene, PPE, proper instrument sterilization, environmental disinfection, and specific attention to DUWL maintenance, plus rational antibiotic prescribing. These are your weapons against staph spread in your practice.
This has been a really thorough walkthrough. We've covered staph from its morphology, the clusters, the slime layer, through its incredible virulence arsenal.
The enzymes, the toxins, the resistance mechanisms.
Huge range of diseases it causes, from skin issues to endocarditis and toxic shock. We looked at where it lives, how it spreads.
Emphasizing those hands, aerosols, fomites.
And drilled down into those critical dental implications. Angular chylitis, the endocarditis risk from bacteremia, DUWL contamination, the importance of infection control.
Plus how the lab finds it, the treatment options, and that ever-present challenge of resistance.
Yeah. Understanding staph clearly isn't just microbiology trivia for you listening. It's fundamental to safe, effective patient care.
Knowing its potential role in oral conditions. It's linked to endocarditis, its presence as a carrier, its threat in cross-infection, It informs everything from risk assessment to why you follow protocols so carefully.
And how you make responsible decisions about treatment, including antibiotics. It connects the dots between the microbes and the clinic.
Absolutely.
So here's a final thought to chew on. Given Staph adaptability, the fact that it's part of our normal flora, and this rising tide of antibiotic resistance, especially MRSA, maybe even VRSA, consider this. How will this evolving landscape of resistant staph continue to shape what you do? Will it change routine procedures, demand even tougher infection control, further restrict antibiotic choices in dentistry in the future?
That's a really important question. Something to definitely keep thinking about as you move into clinical practice. Because understanding these bugs and how they're changing isn't just academic, it's essential.